Welcome to this wonderful spring day in Minnesota. And you know, it's 55 degrees out, and I think the sun's almost out, so we're ready to celebrate. I'm Sue Gerberick. I'm Director of the Midwest Center for Occupational Health and Safety. And I'd just like to welcome you to our center's annual NORA Symposium, which this year is co-sponsored by the Midwest Center as well as the Upper Midwest Agricultural Safety and Health Center. We have great participation today that includes all kinds of faculty, students, community, staff, and regional partners from several states, including colleagues from Wisconsin, Iowa, and the Dakotas, many of our advisory board members, and numerous guests. So thank you all so much for joining us. We're especially honored with two internationally recognized speakers from California who will address a topic of great importance to occupational health and safety. Before we commence the program, however, I would just like to thank some very special people who have made significant contributions to the success of this effort today. And I guess it's a little difficult for people to stand up, but just sort of wave your hand. Pat McGovern, who's Deputy Director of our center, Julie Alcorn-Webb, our center's Continuing Education Director, Maggie Truax, Program Associate in the Centers for Public Health, Education and Outreach, Joy Archibald, Associate Administrator and our photographer today, Karen Brademeyer, who's Office Supervisor, Deb Grove, Physical Officer, Andy Ryan, Senior Research Fellow, and Ashley Richard, Office Assistant. So thank you all for all of your contributions. I just want to remind you to review the materials in your folders, also that include the listing of excellent posters that we have that we'll be continuing to show during the reception. And please be sure to join us for the reception where we have lots of good food and beverages, so we look forward to talking with you further there as well. At this time, I'd like to introduce to you Dr. Bruce Alexander, who's Director of the Upper Midwest Center for Agricultural Safety and Health. And among many other activities, he's also Division Head for Environmental Health Sciences in his spare time. So thank you again for joining us, and I'll turn this over now to Bruce.
Thank you, Sue, and thanks. I'd also like to join Sue in thanking everybody for coming to this symposium. We're very excited about the topic and the speakers we have here today. I want to welcome you on behalf of the Upper Midwest Agricultural Safety and Health Center and our partners in that center, the not only School of Public Health, but the College of Veterinary Medicine, the Minnesota Department of Health, and the National Farm Medicine Center of the Marshfield Clinic in Wisconsin. I do want to recognize a couple people I think we missed in the thanks, including Diane Campo, who is a coordinator for the Upper Midwest Agriculture Safety and Health Center, who helped organize this, as well as Emmy Waldhart and Ruth Rasmussen, the outreach coordinator, who was also instrumental in pulling all this together. Before I get started, I wanted now to introduce to you Dr. Beth Vernig, who's the Senior Associate Dean for Research and Academic Affairs at the School of Public Health and also a professor in the Division of Health Policy Management, to welcome you on behalf of the School of Public Health.
Thank you. It's delightful to be here today, and on the behalf of the School of Public Health, I want to welcome everybody to this seminar, but more importantly, on behalf of the School of Public Health, I want to publicly brag about these two centers that are sponsoring this. We, in our most Norwegian way, think they're pretty good, which translates, of course, to absolutely excellent and a source of great pride. As you know, the Midwest Center for Occupational Health and Safety is one of 18 centers in the U.S. and has been in existence for over 35 years. That means we have got a long established, important, recognized history of training the occupational health workforce in research practice and providing important, essential, ongoing support for students. And for that, we as a school are very, very grateful and very, very proud of the work that has been happening. Likewise, UMash, the Upper Midwest Agricultural Safety and Health Center, is one of 9 centers in the U.S. dedicated to improving the health and well-being of the agricultural workers and their families. I spent the last few days at a conference about the ICOMOS, International Conference on One Medicine, One Science, and we spent a lot of time talking about issues around the interplay between food, with food in particular, but around the environment, human-animal environment interactions, and worker safety and agriculture safety was very, very frequently mentioned. This is an incredibly important topic for an agricultural state like Minnesota. It's very important for our world, and we're very grateful to the work that these 2 centers are doing to promote this. So thank you very much.
Thank you, Beth. And now we get to the fun part of the symposium. And here again we have Dr. Mark Schenker and Xochitl Castaneda here to talk about occupational health of immigrant workers, reducing disparities. And in introducing him, Xochitl Castaneda is the director of the Health Initiative for Americas at the School of Public Health at Berkeley. She is trained as a medical anthropologist and has done postdoctoral fellowships at University of California, San Francisco, and Harvard University and Amsterdam. She's been working in public health for many years, and as earlier today, as we were discussing some of the work that her center has been doing, is just really very exciting work and important work on how immigrants are being integrated into our country and how the role of being an immigrant and their health status affects many different aspects of their lives and our lives. Dr. Mark Schenker is a distinguished professor of public health sciences and medicine and associate vice provost for outreach and engagement at the University of California, Davis. He's also the director of the Western Center for Occupational and Environmental Health and the Western Center for Agricultural Health and Safety, also an agricultural safety and health center like the UMash Center that's funded by NIOSH, but it was one of the first ag centers that was established. He has a degree from University of California, Berkeley, and a medical degree from University of California, San Francisco, and has done postgraduate training at Harvard. In his postgraduate training in pulmonology, but he's certainly done a whole lot more in his career than pulmonology. The topic today is of incredible importance to Minnesota and the upper Midwest. Beth made the comment about everybody views Minnesotans as being a bunch of Northern European Norwegians who are very uptight and boring. But we're fortunate that our region is now being increasingly integrated with people from other parts of the world at a much faster pace and a pace that's going more and more rapid. It's a great thing for us because it sure introduces a lot better food to the region. But it also is important because people coming in as immigrant families are providing important role as a workforce in many of our very basic industries in the upper Midwest, and how they integrate, whether they're from Latin America, Somalia, other parts of Africa, Southeast Asia. They have an increasingly important role in the upper Midwest. And so this is probably one of the most important and emerging topics in public health, and so we're very excited to have Mark and Xochitl present this topic today. Thank you very much. And so I think Mark is going to start the presentation.
Thank you very much, Bruce. I want to also thank the organizers of this really wonderful event. We've had a great morning meeting with students, meeting with faculty, exchanging ideas, and I hope we can stimulate more of that following this discussion. Bruce Alexander, Susan Gebrick have been really exemplary hosts, and I want to thank them. And also to thank the stars that aligned to put this symposium on May 1st, International Workers' Day. After a lot of scheduling and rescheduling, it turns out that we're speaking on perhaps the most appropriate day of the year for this talk. So what I'm going to do is try and introduce you to the topic of global migration. And so we're all thinking in the same about this and look at some of the demographics and economics of migration, the drivers of this issue, and then shift to the issue of occupational health of migrant workers. Xochitl will talk about the University of California contribution and the programs going on there and that she directs, and then we'll try and end on a note of future direction for this whole effort. So I want to start by this parable. Many of you may know it. Occupational health risk is often like looking for one's keys under the lamppost. The light's better there, but it isn't where the keys were lost. In fact, we should be studying illness and injury among our most vulnerable populations, the ones where the greatest disparities exist, and this is particularly the case for immigrant workers. As I'll try and convince you, we see some of the most needy occupational health issues for this population. And I understand it's difficult and it's challenging to study this population, but it can be done and it should be done. So why don't epidemiologists and others see immigrants and address this issue? Well, in part because they live in separate communities, they're not visible. There are all the difficulties, particularly to epidemiologists, in studying this population. They may speak a different language, different culture, legal status issues, low education. All of these make study more difficult. Our standard reference lists, population lists, etc., often don't include immigrants. And then you may have political barriers and even prejudice that prevent this. So to me, these are the challenges. It's what we should be doing, and I hope I'll provide some direction, as will Xochitl at the end of our talk. Okay, I want to begin with some basic principles of migration. The first one is migration has always been and will continue to be a natural phenomenon for living species, not just for humans, for living species. And this point was driven home to me a few years ago. Well, just to emphasize how common this is, up to 1/7 of the global human population is migrant, that is living someplace outside their place of birth, so approaching 1 billion people. I was thumbing through a magazine and I saw this picture, and I thought, another picture of these migration streams, central stream from Mexico to the U.S., central stream, western streams, eastern streams. We've all seen this map in different forms. And then I realized this wasn't human migration. This was butterfly and sandhill crane and other animal migration. They do the same thing. They migrate back and forth with the climate change, with the seasons. The only thing they don't have are border guards and fences and to deal with. But migration is a natural phenomenon. You can see it in many different species, plant species as well. With humans, we just have difficulty with this because we have nation states and boundaries, and but a lot of the drivers are the same, as I'll mention. This is from just a few weeks ago from the journal Science, and it's a global mandala, I like to call it, of migration. And this is every region of the world. You can look at this online. It's interactive. And it shows you both the complexity of global migration as well as the fact that it's universal. Every region in the world. So I know you can't read it that well, but for example, this is North America here, and this is Mexico. And, this major migration that we have between Mexico and the U.S., but all the other regions of the world have this. In fact, if you click on this, you get the migration by country, and you can even further click on any of these streams and get the number of people. But I put it up to show you that what we're talking about is a global phenomenon. And even though we may use examples from U.S. migration, in fact, the same story exists if you're in Europe, if you're in Africa, if you're in Asia. And, that's to keep in mind. Okay, well, the second point is the major causes of global migration are likely to increase in the future. And what are they? The first one is natural disasters, which have been defined as biologic, geophysical, climate-related, and all of these drive people to move. What are some examples? Well, you just have to follow the news, and these happen with unfortunate regularity. The Indonesian Christmas earthquake and tsunami killed 200 to 300,000 people, forced over 1 million to 2 million people to move from that area. The recent Typhoon Hainan, again, enormous displacement of people. The Haiti earthquake, and then the last one is Bangladesh. And I put Bangladesh up not because of a recent typhoon or event, but because it reflects the slower climate change that's occurring and that's forcing movement around the world. We have islands in the Pacific that are being depopulated now because of rising sea levels, and the several areas in the world, often most vulnerable populations, that are having to move because of the slower climate change. So this is the first cause of global migration. And this is from an article in the New England Journal just this past year, looking at the number and type of natural disasters. And you can see that over the last 30 years or so, there's been an increase, particularly the climate-related disasters, okay, like I was showing you. And this is the net cost of these, and you can argue whether this is evidence of climate change and climate-related change. I think you might win that argument, but the fact is that when you look back over the data, this is very real, and this is forcing movement around the world. The prediction is that we're close to 50 million people, environmental refugees, and that may go to 200 million by the year 2050, people who have to move because of climate-related changes and disasters such as these. Second major cause of global migration and its likelihood to increase is political change or political refugees. And just like with climate change, you know, the news unfortunately comes with regularity about the latest country where the civil war or insurrection or whatever happens is forcing people to move. I try and keep this slide updated, but you know the examples continue driving migration. And this is from the same article looking at refugees and displaced persons, and you see, interestingly, going back to the 80s, that there's been this increase of total refugees, or you can look at it as refugees and internally displaced persons. But this is very real and with us, and the estimate is that something over 40 million forcibly displaced people worldwide now exist. 80%, interestingly, are in developing countries. This is not something, this has much greater impact in Africa, for example, where you have movement between African countries than it does in coming to the developed countries of the world, although there's pressure in that direction as well. So those are the two main causes, but those actually pale in terms of the major driver of global migration. Well, what is that? Demographic and economic disparities. That's what really moves people. People are moving around the world for jobs, for work, for income, and this far dwarfs the number moving for environmental change or political change. And this slide summarizes why that is. This is a farm worker in Oaxaca and in California, and as you see here, 1 hour of work in California equals salary for 1 day in Mexico, if you have the job. So with that disparity, small wonder people are driven to move for income. And that is exactly what happens, and it happens around the globe. Again, I'm using the North American examples. Now, some people have said, they're taking away jobs for Americans. We have to, triple, quadruple the fence so that we don't have this. And, this is particularly the case, in agriculture. Amazingly, this experiment has been done now where farmers said, we're going to reserve some of these jobs for natives, no immigrants. And the half-life of that experiment is about 3 to 4 hours before the natives realize they're not going to last in that job and they quit or leave. So that doesn't work. Now, I have to show this because I just chuckle every time. The United Farm Workers picked up on this and they created a website called takeourjobs.org. And you could fill this out, say, I want to be a farm worker. Everybody's saying we're taking away the jobs. Well, here's your opportunity to get those jobs back. Just fill this form out and send it in. You could take some of those 1.5 million or so jobs doing agriculture. Apparently 7 people signed up, not including Stephen Colbert, the future David Letterman. This was not, it was a good demonstration of the reality that these are jobs nobody else is going to take. And, I just think this was a clever way to make that point. Okay, so a little bit about the demographics and then economics of global migration. There are about 230 million people living outside their country of birth in the world today. Those are so-called transnational migrants. But if you look at internal migrants, internally displaced persons, then that number goes up to 750 million. So this is a huge phenomenon that exists. Now, why is it going to continue? Well, basically, the population is aging, the birth rate is going down in the developed countries, and you have an oversupply of young people and workers without jobs in the developing countries. And so that's the push and the pull of global migration and why it's going to continue, because those trends are continuing. Now, an important part of this whole global migration picture are the remittances sent by families back to their homes, to their families in the home country. The estimate is $500 billion are sent annually in remittances. This is over 4 times the combined global foreign aid budget of all the countries in the world. And I always love the idea that this is money really going to do good things, to put food on the table, to pay the rent, to fix the house, instead of what these global foreign aid budgets are going for big works projects and other things. And this is a significant source of income for many countries. 38 countries, it's over 10% of their gross domestic product. So migrants are seen in many countries as really national heroes. They're bringing money, they're bringing hard income back to the home countries. Okay, on the health side, the migration can have negative impacts and positive in the countries of origin, during the transit, and in the destination locations. And these can be acute problems, mental health, chronic diseases. In other words, we need to think about this in its entirety of the migration cycle. For example, in the occupational health world, what we see is that many Mexican immigrants, if they're injured on the job, return to Mexico because they can't get the care, the rehabilitation, the family support that they need in this country. And so it's part of this cycle of what I would call cost shifting. We're shifting the burden of that rehabilitation to Mexico while they're young and they're doing their work here. And by the way, not getting the benefits from the money that's taken out of their paychecks. Social protections and health are reduced for the majority of immigrants. Less preventive health care, less financial protection for health care, exclusion from health care insurance plans. When studies are done looking at public health measures, what you see is less frequency among immigrant populations. And of course, this impacts the health of that population. Okay, so moving on to make a couple of these points. This one is labor force participation of Latino men or men ages 18 to 64, and it's just to make the point that this is recent Mexican immigrants, the highest rate of working, higher than long-stay Mexican or U.S.-born Mexican Americans or U.S.-born non-Latino whites. Immigrants are coming to work. That's what they do. Now, this isn't telling you about what the working conditions are or the salary, but it's not like anyone is coming here for the social services or other benefits that they might get. And in fact, the issue of those benefits, this is Mexican immigrant adults having the highest level of no medical visits in the past 2 years, as you can see in this left bar, compared to the longer-stay Mexican immigrants and Mexican Americans, U.S.-born whites. The economic analyses basically say the immigrant worker is contributing more to the system than they're getting out of it, and in part because they're using less services for a variety of reasons I won't go into. This is emergency room visits, just the opposite. Recent Mexican immigrants least likely to have visited emergency room, and I don't think that's because they have less need. I think it's because of the barriers to getting those services. And then finally, moving to occupational health. The history of harsh working conditions for immigrants is a global phenomenon, and it goes back thousands of years. This is the Israelites in Egypt over 2,000 years ago building pyramids and other pharaoh cities as the earliest example that I can find. But if we go to our own history in the U.S., we have Upton Sinclair's expose of the Chicago stockyards and the conditions of the immigrant workers there. The Triangle Shirtwaist Factory fire and the death of the young immigrant women working there in New York City, construction work, agricultural work. So this is a common phenomenon that unfortunately is repeated, and when I look at this and I see 1,100 deaths from this recent factory collapse in Bangladesh, I think back to the tragedies, the Triangle Shirtwaist Factory fire, and seeing history repeating itself around the world. Okay, I'm going to shift now to talk about immigration and occupation. And I want to start with a couple stories. And I know I have some occupational health experts from Iowa here who may want to comment. This occurred a few years ago. It was a large kosher meat processing plant in Iowa, and not by chance in an election year, in which the government decided they were going to make an example of this plant. And they organized a raid. Cost $5 million for this raid. The helicopters came in, the black SUVs came in, they had a rented warehouse to process. They arrested 400 workers, mostly Guatemalan, and started deportation proceedings almost immediately. Now, a day or two later, what came out was 9,000 health and safety violations in this plant. And my question continues to be, where was all that money going to addressing the underage workers and other health and safety violations in the plant instead of this raid, which wreaked havoc, put the company out of business, ruined the economy of the town, and in all ways was a disaster. And I think it's evidence of this misplaced priority that we have, thinking this is more important than the health and safety of those workers and figuring out a legal way to have them be able to do that work. Now, that was on May 12th. The same year, May 13th, this occurred right by where I work in California. Maria Isabel Vasquez Jimenez was a recent immigrant, 17-year-old farm worker, was working in the field. She was actually pregnant. She was near her fiancé. and she collapsed in the field because of heat stress. And the foreman, tried some rubbing alcohol to bring her back. They drove her around in a car to see if she would revive. Finally, she didn't revive because it was hot and she wasn't getting medical attention. And she was taken to a local clinic and told, by the way, just say that you were out exercising, not that you were working, because we don't want this to go on our work record. Well, the clinic didn't have the facilities to treat a medical emergency. She was transferred to a hospital where her temperature was over 108 degrees at that time. She went into shock. She had several cardiac arrests, and she died. And I show this because this is a completely preventable disease or outcome. Rest, shade, and water is the prevention, hardly high-tech. And yet, because in part her immigrant status or vulnerability, she succumbed to this, and I think that's the challenge that we have for addressing the issues of immigrant workers. This has been looked at by CDC, and crop workers have 20 times higher fatality rate than do U.S. civilian workers for heat stress, and that includes all the hot industries. And I don't think the risks are different. I think the nature of the workplace and the workforce is different, and that's what contributes to this disparity. So if we look, this is for Latinos, and I'm going to use Latinos because they're our largest immigrant group, but it's illustrative of other immigrant populations. This is where Latinos work in the U.S. Largest number in housekeeping maintenance, those are women. I'll talk about that in a minute. Agriculture, construction, transportation, the three largest occupations for Latinos in the U.S. And here we see the number and rate of fatal occupational injuries, and on the right is the rate, and you see three of the highest: construction, transportation, agriculture. So in part, our immigrants are working in the most hazardous industries, and that's contributing to their higher occupational fatality and injury rates. Now, something else is going on as well, and that's illustrated here. What you see, this is the overall occupational fatality rate, and over this time frame, 15 years, that's actually gone down, probably largely because a lot of hazardous industry doesn't exist here anymore. But this is the percent of fatalities to foreign-born workers in the U.S. And you can see that that's gone up over 4 times in that same time frame. In other words, there's a shifting of occupational fatalities to our immigrant workers from the native-born. This shows the different specific causes of work-related deaths for Latinos, and you can see one bar is going down, that's homicides, but all the rest have been going up over this time frame. So what's happening is there's a shifting of the more hazardous jobs and worse outcomes to the immigrant workers in the U.S. and I think elsewhere in the world. Now, this is U.S. data starting to look at some of these reasons. This is demographic data, and you can see occupational injury, occupational fatality rate, a clear inverse association with education level. Higher the education, the lower the fatality rate, going down to, no high school. Similarly, English-speaking ability in these U.S. data, strong association of injury rate, fatality rate with English-speaking ability, or an inverse association. So we start to get a picture of some of the contributing causes within this population. This is looking at the rate now, even when we adjust for those factors, education level, English-speaking ability, the rate is higher. This is injury and fatality rates, so injury here between higher for immigrants than it is for natives across the board. So clearly the higher rates are there. I showed you some of the factors associated with this. And we can, count those off as significant. But to me, there's one more factor that I think is critical and that doesn't show up in here, and it gets back to Maria Isabel. And that factor is what we call precarious work, often associated with being undocumented. Those are the most vulnerable workers, the ones who aren't going to complain, who are going to do the most hazardous jobs, who are not going to demand the safety equipment. Those are the workers who suffer the greatest rate. And this is harder to capture, but as I say, Maria Isabel was one of those. I'm sure she knew if she complained, if she said, I want to take off and rest and have some water, she might not be hired back. She loses the job. And that's the vulnerability those workers have. We did a study with colleagues in Spain looking at self-reported poor health in relationship to job security. And interestingly, for the foreign-born, the poor health was, or good health was best among, if you were a permanent job contract, worse for temporary workers, and if you had no job contract, much worse. And even for the Spanish-born, you saw this association. So job security associated with health outcomes starts to get at this precariousness issue. These are data from Washington State, basically showing that using workers' compensation data, temporary workers had higher injury rates than regular employees, higher time loss, but lower time loss costs and lower medical costs. So, supporting this idea that job insecurity is associated with worse occupational health outcomes. So I want to just go to a couple of industries to highlight a few more points, and then we're going to shift. Agriculture, something we all know about. In California, 90% of our farm workers are immigrant. And I'm not going to show the data except to say the range of occupational hazards in agriculture covers the textbook. Everything from skin disease to toxicity of pesticides to respiratory problems to heat stress, and higher adverse rates than non-agricultural workers. This is a job category that many people may not think about when they think about industries, but in fact day laborers is a major employer for immigrant workers. Difficult one to study, but the studies done show about a 50% higher rate of occupational injuries and higher disabling, higher required job transfer because of the injury. And also, interestingly, less than half get workers' compensation in this situation, even when they're entitled to it. Construction work, another one of the major employers for Latinos in this country. And I just want to show one study, it's interesting, where they looked at the Census of Fatal Occupational Industries and fatality rates for Latino or Hispanics versus non-Latinos. And what they found was that even within the same job category, say roofer, if you were Latino, you were almost 2 times as likely to have an occupational fatality than a non-Latino, same job category. So these factors are affecting these outcomes in ways that we don't totally understand, but suggest that the immigrant worker is more vulnerable. And then I want to talk about domestic cleaning. This is, of course, where many women work, and conditions, vary from, acceptable to ones highlighted by this demonstration that was in England a couple of years ago. I was in a prison, a cage, just like a slave. The United Nations has adopted a statement on protection for migrant domestic workers, but of course the UN has no ability to enforce that, and it's a nice statement like the Declaration of Human Rights, but by itself it doesn't make change happen. This is a recent review of foreign domestic workers that really found this type of situation as very common, working 14 to 18 hours a day, no rest hours or days, over half reporting underpayment, substandard living conditions, other abuses. This is a significant hazard, and again, one with an immigrant workforce in this country as well as elsewhere around the world. Now, bringing this to my field of pulmonary medicine, this was an international study looking at risk in household cleaners of asthma symptoms or medication or wheezing, and showing significant increase. And when you start to look at what's in the household cleaners, of course, this isn't a great surprise. So I was in Barcelona and I said, why don't, you have the data from the European Respiratory Community study. Can you look at the immigrant versus the non-immigrant workers? And sure enough, what you saw was that for the non-immigrants, there was actually a not significant increase in small but not significant increase for asthma and no increase for bronchitis. But if you were an immigrant and exposed, a significant increase, 4 to 6-fold in asthma or chronic bronchitis with exposure to toxicants indoors. And this is a phenomenon that I've seen many times. When you start to look at the immigrant versus the non-immigrant, what you see are the worst occupational health outcomes in the immigrants. And finally, I just want to say there is the criminal extreme that unfortunately exists for immigrant workers. This was a case a few years ago of a U.S. citizen, immigrant from Dominican Republic, who was convicted of selling fake asbestos removal training certificates to foreign workers. So she would get these workers vulnerable, say, I can get you a job, just give me so much money and I'll give you a certificate that says you know how to remove asbestos safely, and then sends them out to get the jobs. Unfortunately, these types of things exist. Okay, well, that's my piece, and I hope I've, convinced you of some of these facts and certainly sensitized you to this issue. Xochitl is going to now speak about some different aspects.
Okay. So it's difficult to be after you. I think you share a lot of issues related to migration, the relationship of migration and occupational health in a fantastic way and comprehensive from many perspectives. I would like to share with you what has been done by the University of California and what we look forward to see perhaps and continue doing with the University of Minnesota to translate a lot of the research into rehumanizing migration. In this world, in this neoliberal moment of the humanity, we forget a lot the human part of the people who's feeding us, the people who is constructing our cities, the people who is taking care of our children, who in fact a lot of them are immigrants. And as Mark mentioned, they have been not necessarily, they have been forced to move from the countries where they were born. It's very different to choose or to do tourism than to migrate. When you migrate, you leave permanently a lot of emotional ties to where you are born. So in this sense, I want to highlight that we need to replace, in order to rehumanize migration, health as a matter of social justice, as a matter of human rights. I don't understand why in the same county of Los Angeles we have 15 years of difference between one neighborhood to another. What is this happening? Why in a democratic country like the United States of America we have these differences in life expectancy in a single county. I imagine that perhaps in Minnesota is the same. If we go to areas where are populated by a large concentration of immigrants, you will have these same differences in life expectancy. So we need to do better our homework as people who would like to contribute to have a more just world and a better world. And I want to highlight here that the migrants' health go beyond the migrants themselves. The health disparities of the migrant population are affecting not just the individuals themselves and their communities, but second and later generations. When we see, for example, what are the demographics of Mexican Americans in the previous graphs, you see that they are kind of close and very different compared to the native population. So this is affecting not just themselves, their communities, but also the countries and the countries of origin, sometimes the places where they transit, and the communities of destination. And because of that, we have developed a series of programs where we truly believe that in order to change these disparities, or at least contribute to the change, we have to work from a binational perspective. If we just place the blame here, okay, it's the fault of the United States that these people could not access health like the natives do, and the countries of origin are not taking care or contributing to solve this, being those migrants, as Mark mentioned, the people who is contributing so enormously with their remittances to have food in their tables, in the places they left. So we have developed a series of binational programs in which the countries of origin are actively participating. We started with Mexico because Mexico is, by far in Latin America, the country that loses more population due to migration. It's, by the way, is the third in the world, just after China and India. And we expanded our experiences from Mexico to other Latin American countries, and we hope now to other countries around the globe. So this is what the University of California is doing. We have installed 3 centers. The first one is a 10 campuses center. It's part of the UC Global Health Institute, which has 3 centers, one of them on migration and health. We have over 45 faculty involved. We just had Global Day on Saturday, preceded by President Napolitano at the UC Davis, in which faculty, students, and the associated programs of UC are contributing to the 3 centers, including the migration and health, to propose solutions. As it was said, we are researching for the world. The Migration and Health Research Center, which is a joint effort between Davis and Berkeley, and the Health Initiative of the Americas, which is the program that I direct, and it's the one that I'm going to share with you some of the things we are doing. What we do, first of all, who we are. Well, we are a program at the School of Public Health. We have a central headquarters and 3 regional offices in San Diego, in Mexico, and in Spain. And you will say, why in Spain? Because after the U.S., Spain is the second largest country that receives more immigrants from Latin America in the world. So we are trying to replicate and to work with the countries of origin also in Spain. But what really characterizes the program that I have the privilege to direct is that we are one of the largest network of volunteers in the continent. Over 20,000 people participate in our programs. People who really want to contribute to change the disparities of this population and recognizes that without the valuable contribution of immigrant workers, perhaps we will not be here today, or at least not fed or not with the great privileges we are in the universities. We work not just with Mexico, but also with other 7 Latin American countries. What we do is one thing. We are monolithic. We do migration and health. And Mark, the stars were aligned. Today, it's a day that all over the world, not necessarily here, we celebrate Workers' Day. It means workers who are the ones who experience precisely a lot of the occupational fatalities, and precisely a lot of them immigrants. So we align our to-do with the 4 pillars of the university. We provide research resources, and on that we have been collaborated with the University of Minnesota, and we hope to continue collaborating in a program called PIMSA for its Spanish acronym. We do teaching. I teach and we train not just UC students, but also promotoras, people from the clinics on the specific aspects of migration and health. Why mental health could not be the same for a people from the same socioeconomic level than a migrant person? Well, we try to sensitize the providers on that and develop innovative approaches. For example, scales on mental health or some training manuals to refer to agricultural risks, because the immigrant population do not internalize risks, react to them, or have the same health-seeking behavior, for example, that a person who speaks English or who has some knowledge of how the system works because it's native. The public service part is very important. We do events throughout the year that bring services to those who do not necessarily access in a regular manner the health system because they cannot afford it or because they are not eligible for subsidies, which is recently the big problem with the ACA, the Obamacare. And we try to influence policy. We are very present in Sacramento as well as in DC and try to translate the research generated in our university through our programs, through our effort programs with other universities, and inform those to take decisions to do it in an informed manner. Unfortunately, not all the battles have been gained because we couldn't pass the regulations for undocumented workers under the ACA. These are just some examples on how we conduct our research. This is some of the research centers we have, the Migration and Health Research Program, and we develop, for instance, a series of directories of researchers, national researchers or international, including Mexico and other European countries, that are conducting relevant research on selected topics on migration and health. And we produce a specific publications based on that research, publications that go for decision makers, publications that are peer review, or publications that go to the media and try to influence and change the narratives about immigrants and their health. We develop a lot of resources, so we are really active not just in the publication, but in the public action. For instance, in California, now every ambulance of the state has one of our dictionaries of health-related terms that these Latino immigrants have vis-a-vis health, but also the perception of the body, health-seeking, including non-traditional approaches. Because when somebody's sick, well, it's what they are going to say. We also develop a series of popular materials like this guide of programs. We have like 2 million yearly distributed among the Latino population in the state of California, in which in a very easy way we explain, for instance, what is medical, who's eligible, what are the documents you need to bring, etc. So that's part of the services we do, and that's why we said, well, we are going beyond publication to public action in the public health arena. In the public policy, we bring together decision makers, promotores, researchers, people from the clinics to have a dialogue on what are the challenges they are facing, everybody from their own perspective, and the possible solutions to those challenges when they are working with the immigrant community. And this has been fantastic, because a lot of the policy makers who have attended our meetings have gone back to their constituencies and have issued some laws that are benefiting this underserved population. We see now a lot of opportunities, but also a lot of challenges in the arena of health policy. I always said, well, the ACA can be seen as that film, The Good, the Bad, and the Ugly. The good means we have it, even though all the resistance and the constant battles to remove it, we have our health reform. So needed, benefiting so many people. That's the good, and we can talk a lot of the good parts of that. Well, the bad is that the immigrant population, even though the documented population, will not be able to benefit from our health reform immediately. In the best scenario, they will need to wait about 5 years of waiting period for receive medical and federal subsidies of the ACA. You know, this is critical, because, as Mark was saying, this is a population that is working in the most hazardous industries and that is exposed to a lot of risks. And health do not recognize borders, do not recognize papers. So if you are really exposed to those things, well, you will need some immediate action, not waiting 5 years. But the ugly part is like the waiting period for the undocumented immigrants. If, in the best scenario, if we have immigration reform, those undocumented immigrants that will go through the process of regularization will need to wait 13 years to be benefited from our health reform. In what other country, in what other part of the world we are seeing this? Health should be universal. You know, health is a human right. And that's what I started. We need to rehumanize migration and put this in the perspective of the human rights perspective. We see some possibilities now, and again, I would like to link this with the co-responsibility that the countries of origin should have with their population, with their diaspora. If we have immigration reform, perhaps it will be a great opportunity for us to develop a binational health insurance. Because people, even under a probatory or temporary immigration card, will be able to go back and forth. And that's where the countries of origin that highly benefit from the remittances and the contribution of this population will be able to cover the health needs that are not covered in this country. So I see that this is a fantastic moment. We need some paradigm shifts, and perhaps, Mark, you would like to end up with those perspectives for the future.
Thank you, Xochitl. It just occurred to me as she was speaking that I might want to emphasize, again, the dynamic nature of migration. And for those not aware, the net migration between the U.S. and Mexico is now zero. There are as many people going south of the border as there are going north. And the prediction is that there will be 7 million migrants going from the U.S. to Mexico and Latin America in the next decade. And all the more reason why we need to understand and address this, because it's a shifting landscape, and, you know, the flow doesn't just go in one direction. So it is something we need to do. So let me just briefly say that there are people thinking about this. This is from a global consultation on migrant health that was held in Madrid under WHO auspices. And the first thing we need, as Xochitl mentioned, is a paradigm shift. Not thinking about migration as something we have to put up borders from and protect ourselves, the security, disease, you know, how can we create walls, but thinking about this as in a multidimensional way. How do we reduce the inequities? How do we reduce tuberculosis, you know, in Mexico and in the U.S.? How do we deal with infectious diseases? How do we provide social protections for health care, address non-communicable diseases? I haven't even spoken about cigarette smoking, one of my favorite topics in migration. You know, we need to think about this in a multidisciplinary, multi-country way instead of this, you know, borders that somehow are going to protect us from migrants. We need new operational frameworks that take into account this, you know, migrant status, so that we look at and monitor the health status of migrants. And when we identify issues, we can focus on them and create systems that address them instead of, you know, not collecting data and pretending there's no problem. We need to put these into the policy frameworks. I mean, we're talking about public health, and to me, public means everybody, and the policies need to address that. And as I said, they need to be multinational approaches. So just to end, this is a book that we've co-edited. It's coming out, they tell us, in August, University of California Press. And it's a book to provide the tools for studying migration and health. Now, I understand this is challenging, it's difficult to do these studies, but what we have is a book that covers both quantitative and qualitative methods. It looks at cross-cutting issues of language, of culture, legal status, you know, trying to grapple with the issues so that people aren't afraid to take this on, because I hope you're convinced that it's something important for us to do. And then the Summer Institute was mentioned. This is something we put on annually. It's a very low fee. We have a great attendance. It's really a fabulous program for anyone interested in working in this area, networking, meeting people, getting tools for doing this. So just some of the effort. Thank you all for your attention. If you're under a certain age, you can go to Twitter and get our feeds on migration and health. And it's been a real pleasure. So thank you. Yeah, sure. We're glad. Questions, Xochitl? Let's kind of turn this off. I don't know how to do that.
Hello. Yeah, my name is Maria. I have a question. So you have been able to identify like what are the issues and the barriers and what are the things that need to be done, right? So I guess my question right now is, in the meantime, while we're trying to figure out what to do next, okay, how can we be able to help those communities who are being affected? Let's say, for example, like you know that this health insurance is going to be is being non-accessible for a lot of undocumented who are working, right? So they can't seek medical attention at this moment. So in the meantime, while we're trying to figure out what to do, what can we actually do in place? Does that make sense?
Yeah. I think the response could be at multiple levels. I will simplify at least at 3 or 4. First, at the system level, we have to push to have immigration reform. We have to push to have laws that protect these workers. For instance, in California, the Latino caucus is proposing that in California, the interpretation and the application of the ACA, cover California is the name, also include undocumented workers. It's a senator who is proposing that, and we are moving it with the unions, with a lot of communities, with the universities, documenting. We are producing relevant research that shows not just the benefits in terms of health, but the economic benefits of having a healthy population and how it will benefit all. So that is at a system level. At a community level, I think there is a great space to innovate with programs, and that could be to refer or to let this population know what is available, because there are a lot of community resources or resources at a community level, but this population do not know. And when we talk about language barriers, cultural barriers, we tend to be very simple. But language barrier is a huge barrier. And cultural barriers, it's so difficult to navigate the U.S. health system, even for us. Imagine now it's so fragmented. It's very different. I don't know here in Minnesota, in the state, but in California, there are differences between one county to another, even between the cities. How do you imagine this population who do not speak the language, who do not know that they need health insurance? What is that? In the countries of origin, some of them do not ever have insurance. They go to the community clinic. Also, at the personal level, I think in our day-to-day activities, we can pass the information to people about what's there or how to prevent certain risks that they don't know. The majority of immigrants, at least from my country, Mexico, come from urban areas, work in agriculture. So they are not used to the risks that a farmer, perhaps that comes to a farm industry, will know. Or they come from very different environments. So they are exposed to a lot of things that perhaps in an individual level we can do. So those are the 3 levels: the policy, the community, the individual, and don't forget the binational or multinational level. Because I insist it's a co-responsibility, not just of the country of origin, but the transit and the destination. And in the transit, I include Mexico, and I blame Mexico for the treatment, for instance, they do with Central Americans who are heading north. Yes?
I'd like to ask if the influence of non-traditional healers, curanderos, or traditional if you want, but outside the system has been studied so that they provide a level of health services that goes undetected.
Beautiful question. That's something that we have tried to do and embrace. This population have a different health-seeking behavior because they have even a different way to perceive illness, even the body. And for instance, during Binational Health Week, that is this event that we put together every year, we provide services to over 500,000 people throughout the network of all the consulates we work with. And I have to say they do a fantastic job, the consulates. I know there is a consulate here in St. Paul where you can volunteer in their Binational Health Week or in their Ventanilla de Salud. Here we have a representative. We have bring traditional healers, And trust me, it has been a huge success. In the Central Valley of California, curanderos from Oaxaca, or in San Francisco, California, curanderos mayas coming from Yucatan to provide services to their immigrant communities, subsidized by the governments of the states. Yeah.
I would just add that I think our medical education here also has to have the cross-cultural educational component, so people understand different perceptions of health and different needs and different expectations, and just to give that addition.
I have one question. I'm fascinated by the repercussions of the ACA, the act itself, on immigrants. One of the things we know is that if you don't have insurance, you'll be fined. That you'll pay a fine for not having insurance. People who are here without, even with a green card, as you said, they can't sign up for insurance for 5 years. Is that correct? So do you know how that's going to be handled first?
Well, it's more complex than that, because there are some employers that bargain collectively, and those employers could include people who is under the green card and cover them. But green card holders can have insurance. Are the ones who are, I hate the word, legal immigrants who will not be able to benefit from the subsidies of the ACA. And you know, ACA is going to highly subsidize the low-income population. And the majority of the immigrant population is a low-income population. But they have to pay the full amount. They will not be able to receive the subsidies of ACA. Yeah.
Thank you.
Thank you very much for the presentation. It was outstanding. Social, I have a question about, obviously one of the big problems we have in public health is communication with these populations, and I guess it could go to either one of you, but so if you were to give me 3 words to improve our communication with our immigrant populations, what would they be? Or methods of communication?
You read one of my... We have a booklet that is called Lessons Learned on how to approach and provide. 3, talk to me, means talk to them. Do not pretend that this population will understand a medicalized jargon. Remember, the majority of them, English is not their first language. So bring the level of the message basic and preferably in their language of origin. Number 2, approach the services where they are. That's why we call outreach. But we said, this is a very difficult population to reach. You know, the thing is they are hardly outreach. They are not, we don't go where they are. We pretend that they come to the clinics that have specific schedules that compete with their labor schedules, and it's difficult. Number 3, it is important that the message or the services is backed up by trusted sources. This is a population that has been really stigmatized, at least the undocumented, even the documented. When I got my green card, I was the first time that I have to assume that I was an alien, even with special privileges, because I have the green card, but as an alien, So this is a population that not necessarily trusts the system. So if you have, for instance, the consulates or some leaders or some community leaders or some local programs that they believe on, they could be a fantastic ambassadors to pass the message or to even bring the services. So in my experience, what we do is a lot of partnerships in order to really serve and have effective channels of communication.
I was going to add the word promotora, which are community or lay health workers, and incredibly valuable in reaching the community, gaining trust, affecting program.
I would just like to make a quick comment. I love your idea about a multinational approach, but right now it seems as though we've got a multinational corporation approach across our border with Mexico, particularly, but Honduras and all through Central America. And I would just encourage everyone in this room to continue to look at this in a broader perspective than simply public health, but the whole dismantling of civil society that we're under attack, that's under attack right now. Mexico is currently privatizing Pemex and their national oil system, which will erode their social network even further. You know, the 7 million people that you're suggesting are going to go back across the border are going back across because of the results of NAFTA and the movement of large pork production and those kinds of projects back across the border for even lower economic costs. So I think we just need to continue to think about this in a broader political perspective, because I think that regional movement in humans has always been normal, but this kind of movement with humans is not a natural event. This is a human-made event.
Yeah, just a clarification. Those 7 millions are baby boomers. There is already 1 million Americans living in Mexico in an undocumented manner. So what we are going to see is an inverse migration, because the American dream will not be possible for a lot of those baby boomers who will now have their Latin American dream in order to live under the reduced pensions that they are having here from the retirement accounts. So it is not just to benefit Mexicans, and that's what I was saying, a multinational approach, but also to benefit the poor people from this country that is going to retire in Mexico because their pensions will have a more capacity of buying over there. Also, there are going to be some Mexicans that are going back because Mexico is a country, in the case of Mexico, that is, it's first of all, it's the 13th economy of the world. And it's a very prosperous economic country. Problems of violence and security, it's subject of other discussion, but it's not in all over the country. But yeah, I think a multinational approach beyond the corporations, it's something that we, the people who are dreamers and believe in human rights, perhaps we need to push.
I would add, we need to address this at multiple levels. Obviously, there's a national and international level, and that's probably the most challenging, the most difficult, and the least likely to succeed. But at the state level, at the regional level, at the city level, I mean, there are a lot of things that can happen. And in some ways, I think this goes way beyond immigration. You know, we have a Congress which doesn't do a whole lot, but we can do things at state level or you know, I mean, you know, the minimum wage. You know, there are a lot of things that can happen that, you know, while we work on the bigger scale that can come into place. I mean, I understand what you're saying.
When we design our programs, we look for 3 things: the binational approach or the multinational. First of all is continuity. For instance, patients who have TB or HIV that need to migrate need to have a continuity in treatment. The other one is simultaneous approaches. For instance, Binational Health Week, we do it simultaneously here and in Mexico. So the resonance is larger. And people is listening to kind of the same messages. And the other ones are complementarity. Those are the 3. So if we start, for instance, a campaign in Mexico, there is a program called Go Healthy, Return Healthy, So we try to give some continuity of the message that they receive over there and here, and complement them. So those are kind of also the multinational approaches. I have to say, not everything is easy, because in the region we have a lot of tensions too. It is a very effervescent region. You know, for instance, the tensions that exist between Guatemala and Mexico, or Honduras and Nicaragua, and they are also places of origin, transit, and destination. So, well, yeah, that's the transnational perspective.
I'm glad that you brought up the aspect of that this migration, it goes both ways, because there are a lot of Americans that are now living in Mexico and enjoying, you know, the lower, well, they get a lot of, you know, health services and all kinds of benefits. There's a big field for medical tourism. I know, dentistry, you can go to your doctor and pay very little. There are a lot of Americans benefiting also.
Yeah, and you know, not just the ones who move in a permanent basis. The border between the United States of America and the United States of Mexico, because we call ourselves also the United States of Mexico, is the most transient border of the world. There is over 1 million people that go back and forth in a daily basis. Over 400 million border crossing a year. And 5%, you know, it's from Americans seeking health services in the border. There is now even an express line in San Diego that is the medical line for Americans. So,
So I wanted to, we're over our time that we'd scheduled for the presentation. We're going to be around in the poster session is still open, the reception until 5 o'clock, so we encourage everybody to hang around and have further conversations with our guests. But I want to once again thank Social and Mark for a very excellent presentation, very informative. Thank you very much.
Great audience.
Fantastic.